Good afternoon, everyone. I'm going to introduce one of the most dedicated people to Hep C elimination as well as harm reduction in the area. And we're actually going to talk about a program that we're piloting called the PEER program. Let me first give an introduction. I'm going to talk about Dr. Divya Venkat. It is my honor to introduce Dr. Divya Venkat, a dedicated physician, researcher, and community advocate. Dr. Venkat has been a key partner in the Community Liver Alliance in developing and leading the PEER program, which is promoting engagement, empowerment, and resources for individuals with lived experience. Her work bridges clinical practice and community engagement, ensuring that patient and caregiver voices are not only heard, but actively shape programs, policies, and care models. She has been a champion in the integration of lived experience into medical education, provider training, and the health system reform, making her a true advocate for patient-centered innovation. Today, we will share insights from the PEER program pilot that we're starting up. We want to highlight how the program is working and will transform patient engagement and provide a model for more inclusive and equitable health, including, obviously, liver health. So please help me in welcoming Dr. Venkat to the stage, and we're going to talk about this PEER program. Dr. Venkat.
Good afternoon, everyone. We're so excited to talk about this program. It's something we've been working on for a few years now, and we'll talk a little bit about its inception. But we've titled our presentation today, Building Stronger Communities Through Lived Experience. Next slide. Oh, thank you. That's helpful.
So when we're talking about the Community Liver Alliance, we are an education and advocacy organization. We develop and run education workshops while building awareness around liver health, liver disease prevention and management in our communities. We collaborate with partners, many of them in this room, also interest groups, community leaders, and policymakers. We want to help address critical liver health issues. We don't want to reinvent the wheel. As Susanna often says, we believe that we are firmly stronger together, and I'm really big on the saying, teamwork makes the dream work. We also do direct support through our Liver Hero funds. We provide direct service to patients, research initiatives, and specialized pediatric programs, excuse me. CLA definitely has embraced harm reduction, which is, as I mentioned yesterday, meeting people where they are, but also not leaving them there, both as a practice and a theory. We want to help work through the health disparities that are out there, and unfortunately are seemingly going to get worse and worse if we don't continue to advocate, and we support all forms of liver disease recovery.
So before we start talking about what PEER is and how it came to be, I just want to talk a little bit about why incorporating people with lived experience is so critical to the work that we do. So there's been a lot of studies on this. This isn't the first time this is going to come up, and hopefully not the last time, as we think about remodeling healthcare and really making a more equitable future. So one study actually showed a significant reduction in hospitalization risk for people with severe mental illness, especially in people with perinatal depression. And that's incredible, right? Just hiring someone and working with someone who has lived experience can actually decrease hospitalization. If there are any health systems in this room, I hope you're listening, right? So this is something we can invest in to actually decrease and increase our return on investment. In people who are young adults, we also saw a reduction in things like anxiety and even improvement in self-esteem. Substance use recovery, which is where this is probably talked about the most currently in our healthcare climate, this actually shows measurable improvements in treatment retention. So that means that people going back to see their provider and people actually using the medications that they've been prescribed. We see reduction in return to use rates. That's incredible. We actually have some science that it isn't just about the medications, but actually engaging populations to help people not return to substance use. And overall, if you look at all the studies, there's been an 83% positive health impact of peers and how peers actually affect health outcomes. Oh, this one, right? And this extends beyond just marginalization. This extends into chronic disease management, which is what I think we should try to talk about today. Even in diabetes self-management, we see a reduction in hemoglobin A1C levels. Again, we're saying that by putting someone with lived experience in the same room as someone with diabetes with a really high hemoglobin A1C, we all know insulin's hard to take, but you can actually improve hemoglobin A1C levels. Additionally, just quality of life. You think about how when someone is going through a hard time or dealing with a new chronic disease, how difficult that can be. And so engaging, again, someone with lived experience can actually improve someone's quality of life, which is a metric I think we all need to be looking at a little bit more. And just from a health system perspective, they actually also saw improvements in general health outcomes with recipients from people who engage with peers, including things like increased physical activity and better mental health outcomes. So really we're seeing at least a 65% success rate in those studies where peers are engaged and we're looking at health outcomes globally.
So we talk about lived experience. This is why lived experience in settings work. First off, it's about empowerment and self-efficacy. So when you see other people managing similar conditions, it increased beliefs in your ability to recover, to be more well, to significantly improve motivation and treatment engagement. Also, the experimental knowledge is really important. It's one thing for folks to, say, maybe in a piece of literature or in a video far away that they have done something. It's another thing when it's consistently around you on a regular basis. As someone that's around a MAT program or MOUD program, knowing that we had people who had gone through the trials and tribulations and eventually got to the point where they could either volunteer with us or be full-time or part-time employed with us was a really big deal to the other participants who were now coming in the building and in many ways trying to be where some of their friends and certainly their peers were at that time. It helps build that authentic connection. So lived experience provides authentic empathy that creates immediate trust. It helps reduce stigma, and it offers hope through real-world recovery examples. Effective programming means careful design, it means peer supporter training, it means healthcare service integration, and it means ongoing support. And we know that group-based interventions also show particular effectiveness in making this happen. So to give you guys a heads up, we had several viral hepatitis summits here in Pittsburgh. The last time was at the Cambria Hotel. It was a very well-attended event, like I hope all of you feel, a very informative event. And towards the end of the event, we had two panels around viral hepatitis where we had people with lived experience that were scheduled to attend. We had a rural version and then we had an urban version. And the rural version went off without hitch. It was an amazing experience. Actually, now that I think about it, I do want to give a shout out to Lil Prosperino, who was the moderator on that panel and passed away about 2 to 3 months ago. So rest in peace to Lil Prosperino. But that went really well. But then on the second day, our urban viral hepatitis summit, we had several folks who couldn't make it either through work or emergency, transportation, you name it. And that was kind of the inspiration for the peer program. We could have, because it was at the end of the session or end of the day, decide to, not have it and just say, hey, it's over. But what wind up happening is I wind up grabbing the microphone and having a conversation, and we had one of our attendees from Virginia offer to come up and sit with us, a person with lived experience, and we just talked about how challenging it was, but how worthy of an investment it is to have folks with lived experience here in settings like this, and how it's really needed, but that we need to help build capacity around that. And so we said, what if we started local to start a program that work to engage different organizations in their peer population and give them education for, let's say, a 6-month to a year period. I mean, mind you, this is what we were thinking at the time. And that's when we decided to get organized. Dr. Venkat quickly jumped in, Allison Cost, who is our longtime Hep C, maverick, maven leader, myself, and also Natalie from Adagio Health. We all started doing committee meetings and started trying to put together what this peer program would be, and we're right on the precipice of making it happen.
So what does PEER stand for? So PEER stands for Promoting Engagement, Empowerment, and Resources. So our goal is to empower people with lived experience, especially those who have been affected by hepatitis C. I think one thing you've heard about throughout this conference is that hepatitis C is extremely curable, but we're not able to engage with populations who actually need it. And Dr. Talal actually talked about it in his presentation about how this is something that we can do, but how do we do it? And I think one thing I've seen in my clinical work is that a lot of our patients are so interested in getting tested and treated for hepatitis C, but we're not actually getting to them. They're not able to come into our clinics, they can't walk into a hospital, and there's so many reasons for that. So the goal of this program is to have people with lived experience get trained into being advocates for themselves and helping bring people into the fold of healthcare. So our goal is to build leadership capacity, community trust, and peer-driven solutions. I think it's super easy for me as a clinician to say, well, we should just treat this, let's get this done. But there's so many barriers that I definitely don't understand. And just like Clayton alluded to, bringing people in who have had lived experience, who have had this treated, and maybe not in the easiest of circumstances, I think that's really how we're gonna work towards elimination of hepatitis C. We're really focused on Western Pennsylvania, especially Allegheny County. That is where we're currently situated.
Can I also say something?
Yep.
Let me also add that while the liver health and the hepatitis is definitely one of the main points, I think that we want to create folks who are, in a year or 2 or 6 months able to come up on this stage and speak to you like a lot of our other folks with the lived experience have spoken to you in such eloquent and empowering and passionate ways. We'd like to build people up to be able to go to their local governments, to their local health agencies, and really feel confident in a set amount of, sessions, like 6 sessions in like a 6-month period about advocacy for yourself, advocacy for others, what HIV and Hep C look like, what is harm reduction, and some other topics that we want feedback from that peer cohort about. And we want this like state, local, and also federal level. We'd love to, empower these individuals that we have to like be able to advocate for themselves, but then also like in the future when we have events like this, we can say, oh, there's 20 people that we know because they've been through this process that we can call on to, do events, and hopefully it can build to them like getting a job or being able to consult or be able to, speak about a topic and be a subject matter expert that we know they already are.
So based on that, some of our core objectives are, number one, we want to empower leadership. We know that people with lived experience oftentimes come from marginalization, excluded communities, and we want to make sure we bring them into the fold again, empower them to become leaders, and have meaningful engagement with people who may still need help. We want to create authentic participation experiences, and that's so important to us. People from the community actually leading these sessions on how do you treat hepatitis C, what is hepatitis C. We want to mobilize resources that actually connect communities. I think, especially in a place like Pittsburgh, where our neighborhoods are so separated, we want to bring people together in order to actually really treat these diseases. Our ultimate goal is to collaborate with communities. So we do have 3 community partners, which we'll talk about in coming slides, but our goal is to really bring everyone into this fold, every type of community member. We want to make sure we're actually working with a lot of health systems, but I think our ultimate goal is to work with things like the YMCA, libraries, barbershops, anywhere where people might go regularly and we can improve engagement.
So hopefully you guys start to understand why it matters, but to make it clearer, it is about amplifying voices. We're hoping that the peer program is going to elevate essential voices in the community to be the centers of meaningful change, ensuring that those with lived experience lead transformation efforts. Also, we know that there's a lot of stigma out there, and so this is going to help to break down barriers. We know that many individuals with lived experience, they do face health disparities, stigma, as mentioned, and also limited opportunity for leadership in traditional healthcare settings. We hope that, as I said earlier, giving folks the information, learning from them as well will help break down those barriers and give people more of an opportunity. Maybe they'll decide after being in the peer program that they want to continue their education. Maybe they want to get a degree, maybe they want to get a certificate. We hope that, the session will empower them to want to do more, with what they now know. Also, we think that's a part of an integrated care approach. Our program definitely is working to be thoughtful in integrating behavioral health and physical health needs for comprehension and comprehensive person-centered support.
So how will we do this? We want to, number one, empower leadership. We'll talk a little bit about how we will go through this. Promote meaningful engagement by actually providing opportunities for people to engage and develop leadership qualities. We want to mobilize our resources, and we want to capacity build. Again, I think a lot of people who have been through a lot in their lives and do have lived experience, they have something really special. They have something that a lot of us don't have, which is experience that actually can implement real change. And we want to do this through community collaboration. So again, we have 3 partners to start, but we really hope to kind of expand this throughout Pittsburgh and Allegheny County.
So we have had many conversations with several potential partners. Right now, it seems like right now we're going to be working with 3 partners. As far as the participant selection, we're going to be doing a survey of 100 surveys, really short questions, maybe 5 to 7 questions. We want them to express interest in the program, also tell us what they would like to see in the program, and we want to know, do they feel like they've been heard previously when they work with healthcare providers and other social service providers. Then we would like to get 10 to 20 people for this pilot program. We want to include those organizations in the selection of the participants. So if we're doing 10 to 20 people and we get 1 or 5 from one program, 10 from another program, and 5 from another program, each organization is going to be able to help navigate who's going to get selected from the people that did the survey and express interest from that agency. We're thinking that it's going to be 6 to 8 sessions lasting 1.5 to 2 hours each. We're thinking it's going to be both in person and hybrid, and we're currently thinking, in part because of the budget cuts that a lot of the organizations are facing, that we will use our offices at Station Square as the main meeting spot, along with virtual, as was mentioned before. We're going to support folks with transportation, either via public transportation or rideshare. We're going to do Giant Eagle for survey participation for anybody, whether they've been selected into the program or not. But we're also going to do escalating Visa gift card as people continue to complete the program. So, just, to guesstimate, if someone comes for the first session, it's going to be like $25, and then there'll be $40. And, we obviously will have a limit, but if you're doing 6 sessions, we'd like to give someone financial incentives on top of the educational incentives. we want to make it clear that the organizations we work with, we know have people who are already working in the organization that could benefit from the education that they would receive in peer and vice versa. And so we definitely want to keep it open for a few members of the organization along with the participant population to be able to be in the program, because we definitely think that will give diverse representation, and I think in many ways they can be leaders amongst the cohort as well. So, go ahead.
So far, our partner organizations are the River Clinic, where I currently see patients who are coming out of incarceration. Unity Recovery, which is a really wonderful organization here that really helps people who do have substance use disorders, and Adagio Health, which is actually an organization that does a lot of healthcare outside of Allegheny County, but has really been a pioneer in eradicating viral hepatitis as well as HIV.
Are there any questions? And thank you in advance. Yes.
Hang on, I'm bringing the mic up.
Are you guys hiring any particular training organizations to help with your training of your peers or anything like that, or are you doing it all on your own?
Currently, we are doing it on our own education-wise.
Not to say you're not experienced enough to do it, but I'm just curious because we're looking at some things like that. So excellent program. This is fantastic, you guys. I can't tell you enough how much I really appreciate this. What we do at Sober Lovers, this is amazing. I really want to follow you and see how it goes and keep updated on it.
Yeah, thank you, Jen. We're anticipating, starting up within the next month or so with our organizations with the survey. We'll give it a month or two with the surveying, and then we'll be able to pick the cohort. And we're hoping that beginning in next year, early next year or late this year, we'll be able to start those educational sessions for that period of time and be able to graduate, within the next. Well, when it starts, it'd be like a good 6 to 8 months. Yes.
Our ultimate, one of our goals is to then replicate this for other disease states, right? So we're thinking we're starting with hepatitis C, but it could be MASH, it could be PBC, it could be anything. Really, is getting people together to, help each other.
Very true, Suzanne. Thank you. Suzanne, can you pass it to that Kevin?
I'm good. I'm close football. I'm always. Thank you all, first of all. Great presentation. As far as your recruitment techniques, do you all involve your participants in recruitment? And if so, do you all offer them financial incentive for helping them with recruitment?
So,
No, the partner organizations are doing this out of the goodness of their heart and the desire to eradicate hepatitis C. But when people do take the survey, we are going to offer them incentives. We did make sure that the survey was written in, I think, second grade English. We made sure that it was very easy to read. And if someone cannot read, we're planning on talking to our partner organizations in case someone's not able to read, that they're able to actually read the survey out loud. We want to make sure it's inclusive. I mean, that's the goal. I think the goal is to do something like this throughout. These are the 3 organizations we had. I mean, one of them is a place that I work, so that helps a little bit. And the other 2 are just 2 really great organizations locally. We wanted to start it off, initially we actually had this whole landscape of all the places we wanted to implement it, like YMCAs, barbershops, corrections, that sort of thing. But we wanted to start small to make sure we could actually implement this appropriately. I think to your point, making sure our trainings are actually effective for the individuals we're trying to meet. But once that happens, I think we should. I think part of it's also adapting to what each population will need. So I think for corrections, one thing that I think about is even how to obtain employment afterwards might be a really good one, and making sure that we can highlight lived experience for people and show them that there are meaningful employment strategies afterwards.
Yes,
so
sorry. Let me also add that it's also about funding, both from our perspective, but also for the organizations that we're working with. For instance, Adagio Health and their leadership, I want to say probably in July or maybe late June, had to let go of like 50 of their staff. Now, that wasn't necessarily in the program that we were going to be operating out of, but, in leadership, that takes a toll on your overall effectiveness. I would say the same thing for Unity Recovery. They operate a drop-in center on the south side here, and they used to be open 24/7, and now they don't even have a 9 to 5 day part because their cuts, federal cuts affected them so, bad. So we're working with them to implement the program in challenging times for them, and, our partners are feeling it, therefore we feel it. And so we've had to, we would have loved to have started this 6 months ago, but they got hit with, major, damage to their infrastructure and are now working to rebuild themselves. So we are, doing like a lot of harm reduction agencies are used to doing, which is finding a way to make it work, because we know that the folks that we're working with need it more than, we ever could. So it's a work in progress, but we definitely have what you're thinking about in mind, Kevin, and thank you.
I think Susanna over here.
There is. I know there is an initiative about hepatitis C screening, which is the first step in identifying patients with hepatitis, and that happens in the emergency room. And how much did that help with the reduction of hepatitis C prevalence in the, I don't know if it's a nationwide initiative or it's just within Allegheny County?
Oh, you
And
mean like
what are the most the common barrier that you encountered with these patients that you were able to identify?
Well, I think that's the one reason why we want to do this, and I think what that whole conversation was at the Viral Hepatitis Summit was, I think all of us are so passionate about eliminating hepatitis C, but I don't know that we have a great answer for why hepatitis C can't be eliminated. I think that there's a lot of barriers that we have identified through, so Jen Fidner in the back has done some really good work with our community advisory board to identify like what are barriers to treatment. So for example, the screening in the emergency room that was happening, it was like a hepatitis C antibody. There are so many people in Pittsburgh who are hepatitis C antibody positive, but that doesn't mean that they have the virus, right? So number one, we're telling people they have hepatitis C when they may not actually have active hepatitis C. And number two is really hard to roll out the viral reflex testing. And so what would happen is people would come into the ER, they'd get screened for a hepatitis C antibody, they'd be positive, and then there's no phone number to call them back at. So one reason we want to do this is because, one barrier I see for a lot of our patients is they don't have the same phone number like tomorrow, right? They're coming in for an appointment today, they don't have the same number tomorrow. They're like transiently housed, they're kind of like, they're in different neighborhoods. And so one reason we want to do this is to get people who have lived experience who under those circumstances were able to successfully complete the treatment and make sure that their voices are brought to the table and that they can tell us like, hey, this doesn't make any sense. How do we actually get people tested and treated for hepatitis C? The goal is to bring people in and actually they can tell us how we should be treating it. I think there's a lot of things I can guess based on my clinical work, but I don't know that I have the best answers because frankly, I've never experienced homelessness. I've never used drugs. I don't actually know. I can guess, but we'd rather have people who have real experience tell us how to do this properly.
I will also mention that we have a great speaker, Dr. Tuesday Stainbrook, and also Dr. Talal, who will be back, and they will definitely cover a lot of that and more. And we have an awesome panel coming up as well. So you want to know more about hepatitis A, B, C, they're coming up as well.
I'll make a comment. Is this on? Yes. I'll make a comment that during the large study that I described, we had, at the sponsor's request, quarterly meetings with 2 individuals from each of the sites, from each of the 12 methadone programs. And that wound up being a tremendously effective mechanism for engagement, for adherence. And during COVID, when the lockdown happened, we finished a recruitment 2 weeks before lockdown at the end of February of 2020. It became a very important engagement vehicle because patients had already been used to Zoom before pandemic, seeing each other and knowing how to interact on Zoom. And so when they were in their houses, we just moved we had these meetings weekly. And we had Andrew Reynolds from California, an advocate many of you may know, would conduct these meetings weekly and opened it to any of the study patients who wanted to participate. So this kind of engagement that you're doing is really important. And I would encourage you to try and do it virtually as well as much as possible because it can, outside, can become a way to continue engagement.
Thank you, Doctor. Any other questions, comments?
I just have a comment. I think that in light of these organizations like Community Recovery and Adagio, one of the solutions that we're trying to work on and Dr. Stapleton and I are thinking about is co-funding. They're losing funding. Is there a way we can integrate these organizations into the work that we're doing and build them into the budget and help shore up what they're doing? And I think those collaborations are really important. No money, no mission. I'm the greediest fundraiser you'll ever meet, but I also know that if we could raise money and we could bring patients here by, paying for their travel and bringing advocacy organizations, that's important. We wouldn't be here having this conversation. So, it's that investment, it's that sharing, not just about information, but also the ducats. We have to be able to.
That's right, Susanna. What's your favorite motto? Susanna says, well, she says a lot of things often, but when it comes to funding, her motto is one more zero. Hashtag one more zero. We need that. Okay? So I believe that we're going to take a break. Is that right?
There's kind of behind schedule. We do have some great food out there, but if everybody can go, if they want to go, but I would like to keep it going if possible.
Okay. Give me 1 second. Okay. So right now, we're going to have Dr. Talal come back up. Are you ready, Dr. Talal? Dr. Talal is going to speak. Without further ado, Dr. Talal, thank you. Please come on up.
Sure. Thank you very much for the opportunity again to, this was the talk that I was supposed to give. So, not the one I was asked to pinch it. So I'm going to talk about diagnosing and treating viral hepatitis among people who use drugs, and I'm going to focus on telemedicine models of care because I think this is a growth area for the future. Disclosures again. So just so we're on the same page, let's go over a couple of definitions. Telemedicine is the utilization of digital technology to deliver healthcare services remotely. It has the potential to overcome healthcare access challenges for underserved populations, both geographically, temporally, stigma, healthcare fragmentation, and healthcare system navigation. So stigma is an important concept. When we've done interviews with substance users, regarding comparing telemedicine to usual care, they tell us, I like the telemedicine because I have control. If I don't like the person, I just hit the button and I'm disconnected. I don't have to run out of a consultation room and past people in the waiting room looking at me in a strange way. So that's an important, I think that's an important thing to think about. So we conducted a review and searched in PubMed using terms hepatitis, HCV, telemedicine. There were two systematic reviews that have been published on this topic, one in clinical gastroenterology and hepatology in 2021, and one in hepatology a little over about 2 years ago. And we looked at titles and abstracts and really focused on those since 2013 in the direct-acting antiviral era. Exclusion criteria included other digital technology, mHealth, and telementoring. And we really wanted to focus on telemedicine. So just looking at this slide, you can see the growth in telemedicine treatment studies of hepatitis C over the years, starting with 2 in 2017 to 2010 that were published through the end of last year. When we look at the different countries, by far and away, most were done in the United States, 17. 4 were done in India. You can see Spain, the UK, and a few were done in Australia and Canada. If we look at the different settings, and I think this is important because when we talk about meeting people where we are, how do we get providers who can actually go there? Well, telehealth is a way to do that. And just look at the long list. In terms of the number of studies, most were done in the VA, but included here are community-based organization, hospitals, mobile vans, OB-GYN clinics, opioid treatment programs, primary care, prisons, SSPs, telehealth networks, and telehealth networks. And what I think is important is a patient navigator. And the intervention that we tested in our large study had an individual who acted as a case manager. And that was what is represented here, a bridge of trust between a patient participant and the telemedicine provider. So that case manager was involved with providing technical support to bridge the digital divide, namely technology and internet access, and assisting with digital literacy, while at the same time building social support and trust, addressing competing priorities, and delivering personalized care. And this was a very important component that patients mentioned to us during focus groups and interviews, telling us how important it was to have that conduit there. And so, to my knowledge, there are 3 studies so far that have really looked at this. The one that we published last year in JAMA, where I mentioned we had over 600 patients enrolled, 90% response in the telemedicine arm, 39% in the usual care arm. But that study was recently recognized as one of the top 3 clinical trials for 2025 by NIH. And 2 others, which were variations on this theme, peer-assisted telemedicine, that was led by a colleague at Todd Corthius at University of Oregon, and Jennifer Price, hepatologist at UCSF, that did staff-assisted telemedicine. So the peer-assisted telemedicine, in that case, they had a peer similar to a program, you might consider that including something like that in your peer program that was just discussed. So in our study, the case managers were recruited to participate in the opioid treatment program. They fulfilled the role of patient advocacy, scheduling reminders and check-ins, also did Hep C education, and were important with navigating the health system. They were available on site and would meet with the patient when they had their interaction. During their telehealth consultation, that's me showing the liver model. And at the end of the visit, patients, the methadone was, Hep C medications were delivered and dispensed with methadone. This just shows the number of sites and the places throughout the state where they occurred. And in terms of you can see the big the big difference was treatment initiation. So within 5 months, only 40% of patients within the referral approach actually initiated treatment, whereas 92% were started on medication if they were seen in the telemedicine arm. 90% completed for an indication or intention to treat sustained virological response of 90% compared to 39%. And if we think about where we are with national elimination targets of 80%, we achieve that. And as I said, the big difference is in the treatment initiation. So we also found, and from other work that we've done, that 95% of patients recommended the facilitated telemedicine. There was high satisfaction, decreased in substance use, as I mentioned, and minimal reinfections. In staff interviews with 45 staff from all of the 12 sites throughout New York State, we saw that this intervention addresses workforce fatigue, builds trust with patients and staff, and improves reimbursement opportunities. So when you're thinking about how to, and it's reimbursable, because a telemedicine consultation is reimbursable. So, so it's a way perhaps of bringing, of integrating into the workflows of substance use treatment programs. In terms of Todd's study from Oregon, in this it was a peer-supported. They did the screening, the pre-treatment laboratory evaluation, telemedicine visits, and medication delivery and adherence. They recruited 203 participants in 7 rural Oregon counties, primarily through SSPs, outreach sites, and participant referrals. And of note, 70% had experienced recent homelessness. And in terms of, this is just showing the outcomes. In terms of true SVR12, 63% in the telemedicine arm compared to roughly 10% in the usual care arm. But it also shows what happened. And 80% of the patients in the usual care arm did not initiate. This is similar to our 60%, whereas in the telemedicine arm, 15% did not initiate, and 22 were considered treatment failures or reinfection. So basically showing, and in terms of looking at other parameters, primary outcome, the overall, women, ethnicity, and Hispanic, none of these are statistically significant, but all of them favored the telemedicine arm. I will note, I didn't say include data, but in our study, almost all Hispanic women who were treated through facilitated telemedicine achieved an SVR compared to very few in the usual care arm. So for some reason, amongst Hispanic women, this was an intervention that was highly successful. And finally, Jennifer Price from UCSF had a staff-supported screening, counseling, harm reduction, and telemedicine visits. They recruited 111 participants from a fixed community space and also have a mobile van called Deliver that operates in San Francisco, and they go places where people who inject drugs were known to congregate. They also were in the neighborhood with the highest percentage of black people in San Francisco. Staff provided a 2-week starter pack of medication to prevent insurance-related delays, and this was a single-arm study. So unlike the other two I just showed you, there was a single arm, and this is the community research site was a trusted location, considered consistent and convenient. They had a Wi-Fi and a laptop and a private space. The protocol was standard of care, clinician visits via telemedicine with blood tests conducted on site. Staff did check-in and assistance, in-person interactions established trust, and technology troubleshooting, and they clarified provider questions. And you can see here, in terms of just the cascade of care, what happened with the number of participants in terms of how many at each step, how many received an HCV test, seropositive, and down the line, and how many undetectable HCV RNA completion, you can see here was about 60%. And so in terms of summarizing these different models, because I think telemedicine to this population will work most effectively when delivered with a facilitator, you can see that in 3 different types of sites, opioid treatment programs, SSP, and community sites, we're achieving sustained response rates in the area between 60 and 90% through in different in urban New York State, rural Oregon, and urban San Francisco, so 3 different areas of the country. So what are some of the strategies to improve HCV care in jails? It was mentioned a few minutes ago during the question that jails have a constitutional obligation under the 8th Amendment to provide medical care for those whom are incarcerated, and clinical guidelines recommend medical standards of care for these settings, including IDSA, AASLD, the Federal Bureau of Prisons, and the Centers for Disease Control. But some of the treatment challenges are unfortunately treatment challenges that occur in other situations as well, in terms of staffing shortages, stigma among jail officials, providers, and patients, health-related social needs that incarcerated people often face, and high medication cost per patient. So what are some of these? Another area that needs to be discussed are alternative pricing strategies for HCV medications. So there have been these Netflix models or modified subscription models with manufacturers. In the 2 cases that have existed on a statewide level, Washington State and Louisiana, these both states contracted with the pharmaceutical companies with access to an unlimited amount of medication for a set period of time at a capped annual cost. And in both of those models, jails were not included. Some states have dedicated state or municipal budget to fund Hep C elimination, including Philadelphia, which the Department of Corrections settled the lawsuit by agreeing to provide HCV treatment to inmates, recognized the public health value of treatment, and complied with the new standard of care, allocated $14 million within 1 year to treat inmates, and the Department of Corrections partnered with community nonprofit Philadelphia Fight, whose case managers visited jails to provide HCV education and resources to follow up in the community. So just one example of how different institutions can try to make arrangements with community-based organizations to provide services where they may not have the ability to provide on-site. I think there are important lessons learned, and these are some of the ones that have come out of some of the work we did with the focus groups as well as the large study. But you really need to identify a champion. Who's the person going to be at that site who's going to really promote Hep C elimination? Embracing a syndemic approach, not treating Hep C isolated if they have HIV, if they have hepatitis B, other healthcare concerns. And what we have found is that once people trust you, and meaning the healthcare provider or anybody affiliated, they will allow you to be their primary care docs. They will allow you to treat other medical conditions that they may have. And so Hep C and treatment and its successful resolution can be an entree point for engagement in other types of healthcare. You need to be obviously protect privacy. We discuss stigma, address social determinants of health, and include case managers with lived experience of incarceration or lived experience of elimination of Hep C within the care plan. And I think it's important to summarize that correctional health is really community health. And with that, I'd like to thank you. I hope I've convinced you that telemedicine, and particularly with staff assistance, offers an opportunity to treat people where they are, and we need to have more integration, as I think you're promoting, of healthcare community-based organizations within substance use treatment programs. And thank you, and I'm happy to take any questions.